Good afternoon, and again, thanks for the opportunity. So I think the issue of using ACE inhibition, it's very dear to nephrologists because it has shown a lot of benefits in native kidney disease, and whether the benefits that you see in native kidney disease actually translate into kidney transplant is the objective of this talk. So we'll just spend a couple of minutes on the mechanism of hypertension after transplant and some of kind of the general feeling why these agents could actually be helpful and show you what the real data is, whether they're actually helpful or not, and try to end by showing you what is the level of activity of the renin-angiotensin-aldosterone system in transplant recipients. So this is a common slide that people show and talks about why hypertension develops after kidney transplant. And it's very clear that most people go into the transplant with hypertension. But on top of it, there's a lot of donor factors, especially from deceased donor kidneys. There's recipient factors and allograft dysfunction. And there's the issue of medications, be it calcineurin inhibitors or steroids, certainly are associated with hypertension. So try to imagine that you have an agent that actually would address all these issues. I think is too simplistic and too optimistic, in fact. So what would be the potential advantages to think of ACE inhibitors or angiotensin receptor blockers in transplant? Well, they're certainly very effective antihypertensive medications. They're certainly cardioprotective in multiple populations, not in end-stage kidney disease, though. Minimal side effect profile. They certainly become cheaper. They certainly have antifibrotic effect as they move the fibrogenic effects of A2. Certainly an area that used to be a little bit more popular, which is talking about the role of angiotensin II in the regulation and the immune response. A very distinct advantage of angiotensin receptor blockers, not all of them, probably just losartan. Actually, it's a very effective agent in preventing gout. And if you have patients who struggle with gout, just switching them to losartan actually would help you eradicate the problem. Certainly, they're important for post-transplant erythrocytosis. But my sense for having thought about this for many years is that people like these agents in transplant because they will reduce proteinuria and reduce hyperfiltration. There's disadvantages. Certainly hyperkalemia is one of them. Anemia, worsening kidney function, and cough, which can be avoided by angiotensin II blockers. So what I'm going to show you is four things. Two meta-analyses and two actually randomized placebo-controlled trials. And this is probably the largest meta-analysis from a group in Korea. And they looked at trials that used ACE or ARB on patient survival. And the summary of this one, they actually noted that patients, transplant recipients who went on these drugs actually have better patient survival. And I think this is the only study that I know of that actually showed this, and we could talk about the methodology, why that could be. In terms of graft survival, the overall was also significant. So again, patient survival seems to be better. Graft survival seems to be better. But again, this is the only meta-analysis that ever showed this. An earlier meta-analysis from the Ottawa group, which I think is much better done than the one I just showed you because of how homogeneous the studies that they put together. And basically, they found a little bit over 700 research trials that used ACE or ARBs, and there was only 21 trials where patients were followed for 6 months, and there was an active control group. And these are the results. This is the impact of these agents and change in kidney function. If you went on an ACE or ARB, your GFR was lower, as you might be expected. This is the trials that were more than 6 months in duration. Again, ACE and ARBs are associated with lower kidney function. Proteinuria, believe it or not, there was actually no benefit shown for ACE and ARBs to reduce proteinuria. Again, this shows you in trials that lasted more than 6 months, there's no benefit either. Change in arterial blood pressure, which is interesting because we do think of these agents as being quite effective. Actually, they were inferior to calcium channel blockers, to diuretics, to beta blockers in controlling hypertension in transplant recipients. And I actually believe that to be true. If you look at trials that included patients for more than 6 months, you could see that there's really no benefit in using ACE or ARBs versus other agents. Change in hematocrit is not surprising. If you go on an ACE or an ARB, 5–10% of people develop significant anemia. This is true if you use the drug for more than 6 months. Certainly, you see more hyperkalemia with the use of these agents. And I remind you, a lot of these trials were done at a time when we were running cyclosporine levels close to 200 and Prograf level of 15 to 20. So a lot of it just reflects how we used CNIs rather than the ACE inhibitors. Again, hyperkalemia is worse. So you could see how the evidence is really, you can't make much sense of it because the studies that were combined were different. The follow-up was different. So this was an NIH federally sponsored trial that we did before I left Minnesota. And the study was losartan versus placebo in kidney transplant recipients who were randomized 1 month after the transplant. They undergo a kidney biopsy at the time of transplant, and they come in annually for measured GFR, and at 5 years, they have a second kidney biopsy, and the primary endpoint of the study is the change in the interstitial compartment, how much fibrosis is in the kidney between losartan and placebo. There was 150 patients in this trial, and this just shows you the flow, 77 per group. And we were able to achieve the first thing, which is if you want to study these drugs, you have to make sure the blood pressure is comparable between the placebo group and losartan. And you could see the systolic blood pressure achieved was 128, and diastolic it was 68. So excellent control for 5 years of the study. This is iothalamate GFR, and there was absolutely no difference between losartan versus placebo. Remember, this is totally blinded. The investigators, the patients didn't know what they are. Proteinuria, there was also no difference. So if you went on losartan or placebo, your urine protein excretion was exactly the same. And this is measured by first void and also 24-hour urine collection annually for 5 years. What we did see, if you went on losartan, the x-axis shows you the percent change in the interstitial compartment. So a normal interstitium is around 10%. If you get to 50%, that's moderate IFTA. So you could see the blue line versus the red line. The placebo group had bigger expansion of the interstitial compartment than losartan. So there was less fibrosis. However, as I showed you, it didn't translate in less graft survival. So the second study that was done around the same time we were doing the study in Minnesota, this is a ACE inhibitor versus placebo, which is double-blind, multi-center Canadian trial. And in this trial, they randomized patients 6 months after transplant. The follow-up was 5 years. And again, it's the same hypothesis that if you were to control blood pressure with ACE inhibitors compared to other agents at the same level, that you may see benefit. And this is the trial. This trial was a little bit bigger than the one we did. It was 103 patients per group. And the endpoint is kind of the classic renal endpoint, which is doubling of creatinine, end-stage renal disease, or death, and there's absolutely no difference. So I think, when you think about this, I think a lot of people were disappointed. Certainly these are small trials. I think they were very well done, but it didn't show benefit. So I think there's a lot of possibilities. Maybe they're small in size. Maybe we didn't follow the right patients. Maybe we didn't follow them long enough, despite the fact it was 5 years, which is pretty good. But I think it raises two other questions. Maybe hyperfiltration is not what people make it to be. Well, kidney transplant recipients do not hyperfilter. That's one, and you get cyclosporin, which prevents you from hyperfiltration. So I don't think it's important, and we'll talk more about it in the setting of kidney disease, but if you're interested in this area, there's this great editorial which comes after publication from the DCCT, which showed even in type 1 diabetics who have high GFR, actually people with lower GFR progress to diabetic nephropathy much quicker than higher GFR. So this hyperfiltration story, I think, is unfolding a little bit. I don't think it's as strong as it used to be. But the other possibility, maybe the renin-angiotensin system is not even stimulated in this system, in transplant. So if you're trying to block a system that's not active, what kind of benefit you will see? So we actually kind of wanted to look at this, and remember we have those patients we followed for 5 years, and they were on placebo. There were no medications that altered the renin-angiotensin system. So we wanted to see what their angiotensin II or renin activity and aldosterone level is. And the shaded box shows you on top is plasma aldosterone level at the first month after transplant, and the bottom is through the 5 years of the study. And you could see almost 100% of transplant recipients have normal plasma aldosterone level and plasma renin activity a month after transplant. So it's not an activated system. You don't see aldo levels or renin levels that are 5 or 6 times normal. So I think that might be the issue. You're trying to target something that's not even activated. If you do look at the time, over time, the plasma renin activity does go up, and it goes up obviously more with losartan, which this was important to do because you may argue, well, maybe you didn't give the right dose of the drug. Well, the fact that the losartan people have renin activity 2 to 3 times higher than the placebo, it tells you that you were able to block the system. And you could see on the bottom, you actually were able to lower aldosterone level. So it really doesn't seem, which by the way, most people were, the classic teaching is that kidney transplant recipients have a high renin, high aldo state. And if you go back and look at that literature, it's based on one paper of 7 patients. So I don't think it's as true as people thought it is. Now, if you look, you don't have to read any of this because I can't read it either. But the only thing that predicted plasma renin activity and plasma aldosterone was how much sodium you ate. It has nothing to do whether you went on cyclosporin or tacrolimus or MMF. So the activation of the renin-angiotensin system follows the same issues or the same stimuli that you see in native kidneys. We wanted to also study maybe, we didn't, as I showed you, renin went up, so we were able to target the system. But what was fashionable in the kind of late 90s and early 2000 is the ACE gene polymorphism. And if you have a deletion kidney that has the abnormal gene polymorphism and the recipient has the abnormal gene polymorphism, these kidneys may not do well. So we actually went ahead and did the genotyping on recipients and donors, and even the worst combination, which is the deletion in donor and recipient, was not associated with higher aldo or higher renin activity. And this is the plasma aldosterone level. So even if you get this abnormal genotype, if you may, you don't get higher activation. I certainly, when I trained in the lab, was very interested in plasma aldosterone and role in progressive kidney disease, and we were unable to show in transplant that it's associated with worsening GFR or proteinuria. This just shows you iothalamate GFR and plasma renin activity, plasma aldosterone at months after transplant, and you could see there's absolutely no relationship between how the state of the renin-angiotensin system and these measures. So I think to put this together, and I hope this slide shows you how little we know about this. These are the KDIGO guidelines, which think the targeted blood pressure in transplant recipients should be 130/80. There's absolutely no foundation for that. There's no data that ever showed. I think the two trials, ours and the Canadian, kept people at 130 or 128. But there really is no guidance on what the ideal blood pressure is. But that's what generally is recommended. Preferred agent, you could see none is preferred. So feel free to use whatever you want to treat hypertension, whatever drug you're attached to, you know how to use best, has the minimal side effect, is probably the right agent. So in summary, I don't think the renin-angiotensin system is activated, and I think that might be the reason, the main reason why these agents are not beneficial beyond their blood pressure control. They're certainly not superior to other agents. Their use is tolerated. I think anemia is a real problem. I think the bigger issue is whether these agents actually offer cardiovascular benefits, which have not been studied in transplant recipients. And I think the real question really remains, what is the blood pressure you want? Is it 120? Is it 130? Is it 140? And remember, transplanted kidneys cannot auto-regulate. There's no nerves. You can't auto-regulate. If you drop the blood pressure 110, that's the blood pressure they're going to see. If you raise it to 150, that's the pressure they're going to see. So I think we're speaking about two different hypertension physiologies, and hopefully one day we'll have an answer. Certainly, these drugs undoubtedly are very helpful in post-transplant erythrocytosis, and I think we don't see as much of it as we used to because of mycophenolate, but in the Imuran days, everybody had post-transplant erythrocytosis. With that, I'll end, and I'll be happy to take questions later. Thank you.